Welcome back to today's lesson of cholecystitis. I hope you missed me as much as I missed you. Let's go ahead and move on to slide 2 so you can be the nurse who knows anything and everything about cholecystitis. As you see on this picture here, the gallbladder lies right below the liver, kind of nestled in the middle, and its main function is to hold all of the bile that the liver produces. And it's actually going to secrete its enzymes and some other substances which are going to aid in the food digestion process that occur in the stomach and small intestine area. Well, what functions are going to be impacted if the gallbladder does not do its job? We're going to have issues then with immunity, digestion, and nutrition. All of these are going to be impacted and give us issues as regard to the gallbladder. So what exactly is cholecystitis anyway? Well, cholecystitis is the inflammation of the gallbladder, and it can either be acute or chronic. But most often, we're going to deal with the acute problem in the hospital. Let's take a look at acute cholecystitis a little bit closer. Take a guess between what you see on the slide here. What are the two types of acute cholecystitis? Oh, you are so smart. It is calculus and acalculus. That's fancy for stone or no stone. Calculus irritation and inflammation is usually the result of gallstones. We know those as cholecystitis. Fancy, isn't it? Those usually obstruct the cystic duct, gallbladder neck, and common bile duct. The obstruction from gallstones most often occurs in the cystic duct, though. See that in the picture? Cystic duct. Approximately 20% of Americans have gallstones, which is actually a pretty big number. For acalculous acute cholecystitis, inflammation occurs in the gallbladder without the presence of gallstones. It's usually associated with something called biliary stasis, such as biliary inactivity, and this can be caused by any condition that affects the regular filling or emptying of the gallbladder. This type of cholecystitis is most often seen in patients with sepsis, severe trauma or burns, long-time parenteral nutrition or long-term TPN use, multiple organ dysfunction syndrome, major surgery, or even cases of hypovolemia. Now, there is such a thing as chronic cholecystitis. This is when a patient has repeated episodes of cystic duct obstruction and it causes chronic inflammation. Calculi are almost always present in chronic cholecystitis. You can bet that your patient is going to be very jaundiced. Jaundice is that term for a yellow discoloration of the skin and the mucous membranes. And our patient's even going to have icterus. Ooh, what is icterus? I know. Get it? I know. Okay, maybe you're not getting me. It's a yellow discoloration of the sclera. Sorry, I know. Get it? Okay, it is commonly seen in those who have chronic cholecystitis, though it actually can occur in somebody who has acute cholecystitis as well. The jaundice is usually caused by the obstruction of the bile flow. A lot of times we want to ask ourselves, well, what causes gallstones anyway? If that causes the calculus type of acute cholecystitis, well, what causes those gallstones? There may be a genetic component, but this is partially related to family nutrition habits. Maybe the family has diets high in high in cholesterol intake, maybe sedentary lifestyle too. Those are actually two really big contributors. I will say the main risk factors for developing cholecystitis are obesity, type 2 diabetes, dyslipidemia, and insulin resistance. Some independent risk factors include an age between 20 and 60, being female, and of course, family history of gallstones. Well, which race has more cases of gallstones? The races include American Indian or Native American, Mexican American, and Caucasians. Some clinicians refer to the high-risk group of people who can get acute cholecystitis, the calculus kind, the 4 Fs. What are the 4 Fs that identify this group of people? We say female, 40, fat, and fertile. And what I mean by fertile is they are currently pregnant. And remember how I talked about those diets? Diets high in fats, particularly the saturated fats, high in calories, high in refined white carbohydrates, and low in fiber. All of those things increase your risk factor to get gallstones. Now we get to dive into what does the person who has cholecystitis look like? What do they complain about? What sort of patterns are we going to discover during our health history interview? Well, it's good to ask them about when their symptoms occur surrounding food ingestion, and not just food ingestion like a general term. I want you to get real specific and ask about fatty foods, such as when you eat a high-fat meal, do you have any symptoms of abdominal pain or anything, that may lead to discomfort? If they answer, yes, I actually do have abdominal pain with eating those type of meals, or maybe I vomit, maybe have nausea, belching, or dyspepsia, which, do you know what dyspepsia is? It is, I'm not going to tell you, I'm going to make you go look it up. I know, you're welcome. But right, ask about when their pain occurs and specific to what type of meal that they eat. Now, the reason I say that is anytime I hear a GI doctor interview your patient, those are the star questions that they ask your patient. Okay, so who can show me where your gallbladder pain may exactly be if you have cholecystitis? The classic sign of cholecystitis is right upper quadrant pain, and it's actually going to radiate to the right shoulder or to the scapula, to the right scapular blade there. I've actually had some people come in for substernal chest pain, and once we did a cardiac workup on them, which showed absolutely nothing, things were normal with their heart, the doctor went ahead and evaluated their gallbladder. And believe it or not, some of them actually came back having acute cholecystitis. And all the meanwhile, we thought they were having a heart attack. I will say, majority of the patients with cholecystitis exhibit the classic right upper quadrant pain. But you may have shoulder pain. You may even have the chest pain. Now, who can tell me what a positive Murphy sign might be? Me. Okay, I'll pick you. What is a positive Murphy sign? Well, what this is a nurse or a doctor will press subcostally on the right-hand side of somebody, meaning they will take their fingertips and push right up under the right rib cage, and they're going to ask their person to take a deep breath. Now, if a patient, as you're pushing really hard into their right ribs, like right into their liver, if they take a deep breath and they experience pain, they have what we call a positive Murphy's sign. Okay? And this is usually indicative of somebody having an inflamed gallbladder. Another assessment we can do is a test for Blumberg sign, and that's really just fancy for rebound tenderness. I know, right? All these different signs. So how do you test for rebound tenderness? You know this. You push in and you remove your fingers quickly, and you see if they have pain that actually is increased whenever you let your fingers go. That is a positive Blumberg sign. As with any disorder, there are people that may experience no pain and no fever. Older adults will actually fall into this category, and their only symptom may be acute confusion, maybe some localized tenderness. that makes it very challenging to diagnose this patient. And who are those folks who have trouble with their nerve endings, maybe from high blood sugar? Patients with diabetes may also experience only localized tenderness because of all of the autonomic neuropathy that's happening. Our patient with cholecystitis, if you ask them about their bowel patterns and bowel, not patterns, what does their feces look like? They're going to report steatorrhea, which is fancy for fatty stools. This is actually occurring because the fat absorption is decreased as a result of lack of bile. And bile is really needed for the absorption of fat and fat-soluble vitamins in the intestine. So ask them if they have, diarrhea and if there is white spots on it. I just want to throw in there, though, that when we are asking about steatorrhea, it's really common in patients who have chronic cholecystitis, not so much those who have acute cholecystitis. If our person has an extensive obstruction, we may see jaundice. We may see dark urine as well. Which patient is at high risk for the development of gallbladder disorders? All right, the correct answer is C, the 40-year-old female patient with a BMI of 37. Correct. Keep in mind the 4 F's: female, fat, 40, and fertile, which means pregnant. Oh no. Well, what lab levels are expected to be elevated? Well, if we grab a CBC, we're going to see that they have an elevated white blood cell count. If we grab a complete metabolic panel, that's basically a basic metabolic panel that includes the hepatic functions in there, we're going to evaluate their liver enzymes. Their liver enzymes such as the AST, the ALT, and the alkaline phosphatase, as well as the LDH. All 4 of those are probably going to be elevated. We're going to look at somebody's direct and indirect serum bilirubin levels, and if the bile is obstructed, we're going to see that those are elevated. It's, the bile that's going into the gallbladder is being backed up now into the liver, and that's why we're going to see those elevated direct and indirect bilirubin levels. Their amylase is going to be a little bit elevated, as well as their lipase, and this only occurs if there is pancreatic involvement. All of those ducts are connected, so how the cholecystitis, where the cholecystitis issue is going to let us know if the pancreas is going to be involved or not. What diagnostic exam that you see below would be very helpful in identifying the problem for us? The gold standard and best choice to diagnose cholecystitis is an abdominal ultrasound. It is non-invasive and we consider it the most reliable test. We can actually diagnose all stones using this abdominal ultrasound. Other diagnostic exams include abdominal x-ray, but x-rays will only show the calcified type of stones, so it's not effective if the gallstone is made up of another substance. We can complete something called a HIDA scan. A HIDA scan, I forget what exactly it stands for, but it's also known as a hepatobiliary scan. This can be performed to visualize the gallbladder and its patency, like the whole biliary system and its patency. This is a nuclear medicine test where the patient ingests a radioactive let me back it up. The patient is injected with a radioactive chemical through the IV, and they're going to ingest a high-fat meal, which I heard is not really yummy. You have to just eat it. In about 20 minutes, a gamma camera is going to track the flow of the tracer that was injected in the IV from the gallbladder, and it's going to determine the ejection rate of bile into the biliary duct. It's kind of like looking at the ejection fraction of the heart in an echo. Well, now we're looking at the ejection rate of the gallbladder. If the ejection rate of the bile flow is decreased, then this indicates gallbladder disease with obstruction. What does the nurse need to know about this? Well, we need to know that the patient must be strict NPO for the test to be performed, and they cannot smoke cigarettes the morning of the procedure, and we also have to hold some of their narcotics just before this because it can give them a false negative test. We also can do an ERCP, or endoscopic retrograde cholangiopancreatography. Whew, I know. This is another test that we're probably going to see ordered. This is really important to do if the cause of the disease is unknown or if the patient is showing symptoms of total biliary obstruction. Now, a less invasive approach than the ERCP can be performed, and it's called a MRCP, and that stands for magnetic resonance cholangiopancreatography, basically an MRI of the pancreas. And this is going to be done by an interventional radiologist, and the person is going to be given oral or IV contrast prior to having the MRI scan. Do make sure to assess the patient's kidneys prior to this test and make sure they do not have any allergies to contrast. This probably goes without saying, if you are going into an MRI, even though you are having an MRCP, please make sure that the patient does not have a pacemaker implanted. They will not be able to have a MRCP if they have a pacemaker. Oh, yes. In case you need help on spelling that. I'm going to go ahead and pause here. I'm going to let you read it. Please unpause whenever you are done. Okay, the correct answer is B, as in boy. What's the role of the nurse in managing the patient's issues with cholecystitis? Well, first, let's look at the non-surgical interventions that we're going to do. If a person does not have, has not had a cholecystectomy, we are going to stress to them to cut out all fatty foods, meaning no more fast food for you, mister. However, they do serve salads, don't they, I guess. Encourage them to have low-fat diets and avoid gas-forming foods such as beans, cabbage, cauliflower, and broccoli. What can they eat, actually? Well, that's a good question. They can have foods rich in HDL sources, omega-3 sources, such as seafood, olive oil, and nuts. We may see our patient be put on a medication called ursodiol, known as Actigol. What do you think this one does, huh? Actigol. This medication is used to gradually dissolve cholesterol-based gallstones. This is for patients that may have frequent gallstones but aren't really at that point where they need a surgical intervention. We always need to do some patient teaching with every medication that we administer. What does that teaching include? It means they need to report abdominal pain, diarrhea, or vomiting. This may mean that we are not dissolving our stones and that they're actually growing and now becoming obstructive. This medication is limited to 2 years worth of administration, and it requires a gallbladder ultrasound every 6 months, especially during the first year. This is going to determine it's effective or not. Well, let's just say that we still have these gallstones. We don't want to go ahead and do surgery and take a gallbladder out. What are my other options? We can have extracorporeal shockwave lithotripsy. This is a procedure that uses shock waves to break up stones. Kind of cool. This procedure can only be used in those who are non-surgical candidates of normal weight, and they have small cholesterol-based stones with good gallbladder function. Can't just put anybody on the table for this. Sometimes patients do require more than one treatment of ESWL to be able to break up all of the stones. It is super important to educate your patient that they may experience pain during the procedure due to gallbladder spasms or movement of the stones. In most situations, we do give a patient conscious sedation, but it wouldn't hurt to just warn them a little bit anyway, but that we are going to take care of the pain. We can also do something called a percutaneous transhepatic biliary drain. When I worked in the hospital, this was the procedure that I participated in a lot, and it's really kind of fun. Maybe not for the patient so much, but it's interesting to watch. What we do is in a patient who's not a good surgical candidate for the moment, we need to relieve some of the bile that is getting backed up into the liver and then into the bloodstream. So we'll actually use ultrasound to guide our needle and to guide our drain right into their biliary duct. And so now we have a tube that flows from the inside of the patient to the outside, and bile will no longer get backed up in their system. These drains basically divert bile from the liver. What am I trying to say? Okay, I got it now. So I got ahead of myself. These drains can serve multiple purposes of diverting our bile. So there's 3 types of percutaneous transhepatic biliary drains. We can have an internal only drain. This is where the doctor is going to insert a stent where the bile is going to go straight down past the gallbladder into the duodenum. So that's an internal drain. We can do an internal external drain. This is where there will be a bag that comes out, or like a tube that comes out of the patient's right hand side, kind of in their flank area, and some bile will go into the patient just like the internal drain, but then some will actually exit out the back. This is usually a good option if somebody cannot tolerate an internal drain. Maybe their stones are very obstructing. We also can do an external drain. This, if there is a full obstruction, maybe a tumor, who knows what is in there, but an external drain can have a bag connected to it either temporarily or permanently, and bile will then come out the back. Reduction in bile drainage indicates that the drain is no longer working. Can I get an amen? Let me say it again. A reduction in bile drainage indicates that the drain is no longer working. The bile produces a lot of bile, so do make sure to monitor it closely and get with your physician of what is a expected normal for your patient. Do make sure that your person is in PO during the acute phase of this and that they have IV fluid so they don't get dehydrated. When they are less acute and the nausea vomiting ceases, then we can begin putting our person on, say, a clear liquid diet. When it comes to analgesics, IV Toradol is a fantastic drug. It's also known as ketorolac, with a K. Ketorolac or Toradol is an NSAID, and it is commonly given for patients who have mild to moderate pain, and it is fantastic. Patients are like, oh, I feel so much better, and they don't get the woozy feeling like they do with narcotics. That being said, many patients do require IV opioid analgesics such as morphine or Dilaudid, and that's for usually the acute biliary pain. If a patient is experiencing nausea or vomiting, please make sure to give them a drug known as ondansetron. I have a little picture of it right there. We also call this one as Zofran. This is an antiemetic, and it does pretty good in managing somebody's nausea. Last slide are surgical interventions. This is one of the most common procedures done in the ORs in America, so it's a high chance if you go to do clinicals at the hospital and you rotate through the OR that you're going to see one of these. The big question is, can we do it laparoscopically, or do we have to open the patient up? We oftentimes refer to a laparoscopic cholecystectomy as a lap chole. So if somebody says, do you want to see a lap chole, you know what they're talking about. These are the gold standard because they are minimally invasive and there's a lot less complications. Patients tend to recover quicker, they experience less post-op pain, and they can go home sooner and don't require a long hospitalization stay. There's going to be about 3 to 4 small incisions on the abdomen, and they're going to be probably midline at the umbilicus, and then probably more to the right-hand side. When this procedure is done, the belly is going to be filled with about 3 to 4 liters of carbon dioxide. This actually goes for any patient who's had a laparoscopic procedure. So a lot of carbon dioxide is going to inflate the abdomen and allow the doctor to visualize what he needs to, or she needs to. They're going to insert a trocar catheter, and the laparoscope is going to then be introduced through that. They have this little video camera, and they can see all the different abdominal organs on the monitor. The surgeon then dissects the gallbladder from the liver bed, and then the cystic artery and duct are now they're going to be closed. The surgeon's going to aspirate the bile and crush any large stones if they are present, and they're going to extract the gallbladder through the umbilical port. Occasionally, the gallbladder may be so large that they actually have to make another incision to be able to extract the gallbladder. The majority of the cholecystectomies begin as lap choles, and only a few will actually become open cholecystectomies if the surgeon is unable to remove the gallbladder. Open cholecystectomies are also seen more in patients with severe biliary obstruction that requires the ducts to be explored a little bit more thoroughly to ensure that they are patent. It is important to know and to educate patients that they might have some mild to severe abdominal discomfort and bloating due to the carbon dioxide that was used to inflate their belly. This is not a complication of surgery. This is just one of those too bad, so sad issues. So what does a person do with all of this discomfort through in their abdomen, which can actually be felt through their thorax and their shoulders, both of them? What we want to do is to get our patient who is in the post-op period to ambulate. Right. When they ambulate, this is going to minimize that free air that they feel in their abdomen and help it absorb right back into their body. And know, when air is in your abdomen floating around in there, the CO2, it does not then go into your intestine and then you pass gas. That is a false statement, false assumption there. You just absorb the CO2. Okay, for vital sign monitoring, follow the facility's procedures during the post-operative period. It looks very similar to patients who have appendicitis and they have their appendix removed. So you can visit that slide if you need reference. It is also essential to assess the patient's oxygen sat level frequently, especially whenever they have just come out of surgery and they still have anesthesia in their system. Make sure to educate the patient to change positions frequently, to ambulate, to do those deep breathing exercises every hour they are awake. I cannot emphasize this enough. No patient with an abdominal surgery wants to deep breathe and cough. It hurts. It really hurts their stomach. However, if they splint by holding a pillow over their incisions, it does tend to help. So please make sure to do this super simple exercise. Always assess and be on the lookout for some bowel sounds. If not, we could have a problem. However, do know that they are expected to be hypoactive for a few days. Advanced diet as tolerated per the clinician's order. As with any surgical procedure, monitor for signs and symptoms of infection and report those. That one's kind of a no-brainer. Some patients may have a JP drain, otherwise known as a Jackson-Pratt drain, in place following the procedure. So if this is the case, it is important to monitor the tube site, the amount, the color, and the odor of the drainage. And you're going to empty this probably every 6 to 8 hours. And it kind of depends what the drainage is going to be looking like what's considered normal. And a big note on JP drains, they are supposed to be in a squeezed, sort of compressed bulb. Empty the drainage, compress them again. I want to end this PowerPoint with this little piece of knowledge. After your person has their gallbladder removed, they have lost the ability to really regulate how much bile comes out. This matters when a person who's had their gallbladder removed goes and eats a high-fat meal. Their liver, not regulated yet, will actually just dump tons of bile into their GI system, and the patient will experience instant diarrhea. So what this means is if your person has a gallbladder removed, please inform them that for the next few months, they're going to want to follow a low-fat diet. Because if not, you're going to be racing to the bathroom. That's all I have to say. Have a great afternoon or day, whatever.